EI is a 29-year-old man presenting to the emergency room unconscious. Paramedics tell the admitting nurse that they found him laid down on his bed with 2 empty medicine bottles nearby. He had taken all the pills inside by accident, forgetting each time that he had taken some before until both bottles were empty. On the labels, one said vitamin D prescription and the other said phenytoin, anti-seizure medicine. This shows some kind of behavior was happening. The medical team send him in to get treatment. There might still be time to bring him back and prevent permanent damage from happening. Vitamin D excess can be dangerous, but phenytoin excess can cause one to stop breathing. However, this excess is not too difficult to treat. Why was he on seizure medicine? The vitamin D makes sense because seizure medicine can inactivate it in the body, causing deficiency and weak and brittle bones. In the recovery room, EI was conscious again, but he's confused. He doesn't know why he's in the hospital. The medical team ask him why he was taking this medicine, but when he opens his mouth, it reveals he's not really all there. Vitamin D excess can cause confusion by way of causing excess calcium in the blood, but definitely something else was going on. They may not be able to get reliable information from him, but his medical record gives them some clues. 13 years ago, when he was 16, he came to the hospital with a brain tumor. Back then, doctors had noted that EI had suffered from seizures during the first 2 years of his life, and they described them as spasms, where it seemed like he would lose total control of his body, only for him to snap back into consciousness a few seconds later before totally losing control of his body again. A little different from the tonic-clonic grand mal type of seizure, where one will lose consciousness while shaking, but still a seizure nonetheless. EI's dad had had the same intellectual disability, seizures, and masses growing on his skin. Older notes had mentioned that EI had undergone treatment to remove water from his brain when he was a kid, but not many more details were given. And even worse, it really just seemed that he was getting his treatment for his symptoms and sent home repeatedly. Nothing was really solved, and it culminated into a brain tumor at 16 years old. A few weeks before he came in for the tumor, EI complained of random headaches. The pain was diffuse, so it was all over his head, bilateral on both sides, and it would pound so hard that it felt like his eyes were getting pushed out of his skull. His vision would become blurry every time this happened. Back then, they didn't know about the tumor, but imaging revealed that something was growing inside his brain, pushing on the optic nerve, disrupting his visual signal from his eyes, and causing his headache. But how did that mass get there? Surgeons cracked open the 16-year-old EI's skull, and on the right side of his brain, they found the tumor and scooped it out piece by piece. When they looked at it under a microscope, it didn't show characteristics of being malignant. It wasn't something that was going to spread everywhere in the body. It was just something like an overgrowth that was squeezing his brain against his skull, and good thing that it's gone now. But something doctors had noticed before the operation was that EI had strange shaped bumps growing on his skin, especially by his nails. These were similar to the ones that his dad had. At the time, it wasn't clear that these were related to the fact that he had a brain tumor at 16 years old, but shortly after the surgery, EI's vision returned to normal, and he seemed to recover. Everything was great, but over time, it became clear that something was still wrong. 4 years after brain surgery, when EI was 20, a psychiatrist noted that he couldn't read or understand a newspaper. He had dropped out of high school because he just didn't understand anything that he was learning. At first, it looked like EI may have had depression. Medicines were given, but certain ones would cause him to have a headache on one side of his head. Other medicines would cause his right hand to become clumsy, and he couldn't hold on to anything. They did work a little bit, but it seemed like he had a different neuropsychiatric problem instead. And as the years passed, EI would have periods in time where he'd have horrible headaches and episodes of blanking out. He couldn't remember the last few hours that had passed when these would happen. So he was started on phenytoin for these seizures, answering the question of why he was taking seizure medicine in the first place. Back at this hospital now, a conscious EI showed the medical team that he had a pain in his side. A blood test revealed that some of his organs were shutting down. Sound waves were sent into his abdomen, and they revealed that something was there that wasn't supposed to be. When he was sent in for an MRI, they got a better idea of what that was. Both of EI's kidneys were enlarged, and both had cysts growing inside. These are kind of like blisters on his kidneys, but there were at least 50 to 100 of them scattered throughout. His left kidney had what looked like an extraordinarily large, complex cyst, and they looked closer. Sometimes cysts will pop, they'll bleed, and then this will make them restructure, scar tissue and blood clots. The problem is, when doctors looked again at the image, it didn't look like some of the cysts had been bleeding, rather it looked like blood vessels had been growing inside of them, while other parts of them became thicker. Blisters don't typically have blood vessels, but tumors do. And there wasn't just one that had blood vessels, there were multiple. So while he has these cysts all over his kidneys, at least a few of them have started to become something else. But this wasn't his only problem. EI had complained of headaches when he was resuscitated in the hospital. They did a scan of his head and they found multiple growths were in his brain again. These weren't there 9 years ago or 4 years after his brain surgery, so during this time, things were still growing in his brain, his skin, and his kidneys. And given what was growing on his left kidney had started spawning its own blood supply, it means something horrible has been and is still happening. But why? In one extreme, you could suppose that all three of these inappropriate growths are happening independently. Maybe because he had seizures when he was a kid, that his brain was just predisposed to growing masses. And these brain masses look different than what was growing on his skin, and they're definitely not like the blisters on his kidneys. So he might just have the unfortunate situation of having multiple diseases of multiple organs all at the same time, which is really unlikely because they're all the same central problem. Masses are growing on all of these organs. Nothing is degenerating, nothing is breaking off and floating around in his blood. Even if the masses on different organs look different, the same thing is happening to many organs. So we can reason here that it's unlikely that all of these are all independent problems, meaning that we can go to the next case that says that all of these are being caused by the same thing. But what thing exactly? Well, what about toxins? Those can cause inappropriate growths. Some toxins, like heavy metals, cause neurodegeneration, so not the creation of masses. And typically, when toxin exposure stops, then the problems start to go away. But EI had been growing more masses in his body since the time of his brain surgery 13 years ago. EI's mom didn't have any problems, but his dad did. And his dad's problems were similar to EI's, just not as severe. So if two family members have a similar problem, but a third doesn't, and they all lived in the same house, then if it was really toxin exposure, all three of them should have some degree of problems, but it was just two. His mom was fine. And if family may have passed down the same problems, then maybe what EI is experiencing is a genetic disorder. And because our genes tell our bodies what to make, if EI has a genetic disorder, then it's likely telling his body to inappropriately grow things on his organs, explaining what's happening to him. But what kind of genetic disorder is this? The medical team sent EI in for a nephrectomy, a cutting out of the kidney as they removed the one on the left. When they looked at EI's kidney, they noticed that some of the masses weren't cysts, but they were angiomyolipomas. Angio referring to blood vessels, myo meaning muscle, lipo referring to fat, and oma meaning an abnormal growth. An abnormal growth of muscle and fat that has its own blood supply. This explains the blood vessels on some of the cysts, but when they look at the largest mass, they find that it was a different third type of mass. This one was cancer. All of this gives some clues on EI's genetic disorder. Polycystic kidney disease, poly meaning many, is a genetic disease where cysts grow all over both kidneys. EI has this, but knowing more about it gives us some clues. Humans normally have 23 pairs of chromosomes, and this is where all of our genes are. Genes dictate how all the proteins in our body are made, and this is what makes up our physical form. In 1985, the human genome hadn't been sequenced yet, but certain genes were known to be on certain chromosomes, one of them being one part of hemoglobin, the protein in blood cells that carries oxygen. By studying 4 different families where members had polycystic kidney disease, and by studying a genetic marker rooted to alpha globin, and tracking the inheritance patterns in the 4 families, they were able to discern that the gene responsible for polycystic kidney disease was located on chromosome 16. This is important to know because it gives us some more insight on what's happening. But EI's kidney doesn't just have cysts, and the masses on his skin and his brain are different still. This would mean that EI might have more than one genetic disorder. One of the doctors taking care of EI had an idea of what was happening. In 1880, Dr. Désiré Bournville in France saw a 3-year-old girl who was having non-stop seizures who also had acne of her face and a confluent vesiculopapular eruption over the nose, cheeks, and forehead. This girl didn't make it. At autopsy, Dr. Bournville noted that she had masses all over her brain that were rounded islets forming protuberances of variable size in many of the convolutions, a sort of hypertrophic sclerosis, while her kidneys had whitish hard masses. And in 1885, another set of doctors documented that this happened in a mother-daughter pair, recognizing that this tuberous sclerosis complex TSC appeared to be genetic. So, it's a genetic disease that somehow causes inappropriate growths on the skin, in the brain, and in the kidneys, causing tumors, seizures, and intellectual impairment. This is almost exactly what's happening to EI, but how does this link to polycystic kidney disease? In 1987, 107 years after Dr. Bournville described tuberous sclerosis complex, 19 families who had TSC were studied. Scientists had noticed that family members would inherit certain ABO blood types and TSC. ABO blood types are defined by the presence of A and B antigens, which are proteins, so they're made by the genes, and those are on red blood cells. Remember, back then, we hadn't sequenced the human genome, but we knew that the genes for blood type antigens were on chromosome 9. Scientists had noted that there was an inheritance pattern associated with TSC and ABO blood typing, meaning that tuberous sclerosis complex had to do with a gene on chromosome 9, close by where the ABO blood type antigens were. But there was a problem. Some families who also had TSC did not have an inheritance pattern linked to blood type. And this confused scientists because sometimes studies could confirm the gene on chromosome 9, and other times studies would suggest the problem gene was coming from other chromosomes. It wasn't likely that the gene being on chromosome 9 was wrong. Rather, this meant that TSC could be caused maybe with a problem by a second gene. Sometimes patients with tuberous sclerosis complex also have polycystic kidney disease. If the polycystic kidney disease gene is on chromosome 16, then is tuberous sclerosis complex also on chromosome 16? 85 people from 5 different multi-generational families who had TSC known to not be associated with blood type and chromosome 9 were studied. Based on a repeating DNA sequence known to be associated with the gene for polycystic kidney disease, they found that not only is there a second TSC gene on chromosome 16, but that it's right next to the gene for polycystic kidney disease. This chromosome 16 TSC gene was named TSC2, with the one on chromosome 9 being named TSC1. So if one has an alteration in the genes in this particular part of chromosome 16, they will likely have cysts and angiomyolipomas growing together in the kidneys. And this explains EI's problem. Genetic mutations in one particular part of chromosome 16 is causing overgrowths everywhere in the body, especially his kidneys. They were passed down from his dad, who had almost all of the same problems. But now the question is, how would we treat this? You can't just inject chromosome 16 into trillions of cells into his body, and just knowing where his mutations are coming from isn't enough. The question to ask now is, what exactly are these mutations doing? Cell size is tightly controlled. If they're smaller than normal, then maybe some kind of signal is causing that. And if they're bigger than normal, a different signal might be telling them to acquire more nutrients to get bigger. Insulin is a hormone that tells cells to absorb more sugar to start to grow. When TSC1 or TSC2 genes were deleted from a sample cell, scientists noticed that those cells would grow inappropriately huge and they wouldn't stop growing. But when TSC1 and TSC2 were present, like they normally should be, they would limit what insulin could do. And now this should make sense. EI's first genetic disorder causing tuberous sclerosis complex is that he's missing at least the TSC2 gene on chromosome 16. This is causing the cells in his brain and his kidneys and his skin to grow abnormally large, and they can't stop growing. Just next to the TSC2 gene, polycystic kidney disease gene mutations were also taking place, inappropriately growing blister-like structures all over his kidneys, culminating to the point where his kidneys were shutting down. But how would knowing this association with insulin help treat him? In 1965, on Rapa Nui, also known as Easter Island, west of South America, soil was collected. 10 years later, in 1975, a chemical was isolated from that sample, found to be produced by a bacteria, Streptomyces hygroscopicus. This chemical at first appeared to be an antibiotic, but very quickly, scientists found that it was an antifungal. But it also suppressed the immune system when given to humans, so any thought of it possibly being used as a medicine was put away. This chemical was named rapamycin, after the island's name. In 1991, scientists put fungus on a dish of rapamycin. Most of the fungus was destroyed, but some individuals survived. They were collected, they reproduced, and they were studied to figure out why they survived. 3 particular gene defects were identified in these survivors. If these genes were broken, then it means that they weren't normal. They enabled the fungus to survive against a chemical that's supposed to destroy them. And 2 of these genes identified were named target of rapamycin, TOR, creating proteins of the same name. in normal fungus, target of rapamycin gets targeted by rapamycin, and it ends with the fungus not surviving. But cell size also changes. So tumor isn't just something that gets hit by a chemical and enables the destruction of the fungus. It's doing something inside cells. If tumor is stopped, cells get smaller, and if it's amplified, cells become huge. And even more interesting, humans have tumor, and scientists discovered that it's associated with insulin. That's how it tells the cells to gather nutrients to grow. The human version of this is also found in mammals, so it was named the mammalian target of rapamycin, mTOR. Rapamycin attaches to mTOR and it stops it. This causes cells to shrink, and because TSC1 and TSC2 are also somehow linked to insulin, it means that there was one more discovery that would link all of this back to EI's problems. TSC1 and TSC2 genes encode for the proteins hamartin and tuberin. When put together, these communicate with mTOR and slow it down. They keep mTOR in check, meaning that cells don't grow inappropriately. But because EI was missing the TSC2 gene on chromosome 16, mTOR wouldn't slow down. It would create huge cells all the time in all different parts of the body. In the brain, it looked like new masses continuously growing, even after he had brain surgery to remove a tumor 13 years ago that was caused because of this genetic problem in the first place. It manifested as renal angiomyolipoma, allowing overgrowths of vascularized fat and muscle to proliferate all over his kidneys, causing them to shut down. And unfortunately, his mutations on chromosome 16 spanned from TSC2 to the gene right next to it for polycystic kidney disease, and it enabled additional cysts to grow all over his kidneys. If EI has overactive mTOR in his body because he's missing proteins that are supposed to slow it down, then the answer would be to give him rapamycin to slow down his mTOR. But the problem is, there's one more lesion on EI's kidney that hasn't been addressed. The malignant tumor that was the dominant mass on his removed kidney. It was a heterogeneous mass with necrotic tissue inside. Very clearly, this was a kidney cancer, not a cyst and not an angiomyolipoma. However, a second, smaller tumor was just below it, different in color, lacking the necrosis, while being a cancer itself. It's not normal for a 29-year-old to be growing this. This could mean that he has a third genetic defect, but what if it has to do with his tuberous sclerosis complex? TSC1 and TSC2 are known as tumor suppressor genes. This makes sense because their normal presence slows down a machine that makes cells larger. In 2014, scientists studied renal cell carcinomas in patients who had TSC. Because missing either the TSC1 or TSC2 genes will cause tuberous sclerosis complex, they found that if both genes are missing at the same time, that condition alone is sufficient to drive the growth of renal cell carcinoma in someone who has tuberous sclerosis complex. And this is the final explanation of what's happening to him. On his left kidney, there was almost no normal tissue left because growths were everywhere. Because EI had a multifocal carcinoma, meaning more than one malignant tumor, it means that the kidney still in his body would be at risk for eventually also growing renal cell carcinoma. And once the genetic changes inside the renal cell carcinoma start to evolve beyond missing TSC1 and TSC2, rapamycin likely isn't viable to work for his problem. All of this could be fine, except EI would have never been eligible for rapamycin in the first place because his case is happening in 1986. You see, tuberous sclerosis complex was first described in 1862 by Dr. von Recklinghausen and given more detail in 1880 by Dr. Bournville. Doctors had identified EI had TSC as early as the late 1950s when he was born, because it had been known for almost 100 years by then. But in the years up to 1986, there wasn't much that they can do other than remove tumors, remove water from his brain, and give him seizure medicine. It was only in 1987 when the first gene responsible for TSC was identified to be on chromosome 9, and even then, they weren't sure about this because the disease would happen in people who didn't inherit it in the same pattern as they did blood types. And only in 1991, when tumor was found in fungus, and 1992, when TSC2 was identified on chromosome 16, and in 1997, when hamartin was identified as the protein encoded by TSC1. And it was in 2001 when TSC genes were found to interact with a pathway related to insulin in context of driving the question of how big a cell should get, finally linking all of it to mTOR inside cells, giving way for rapamycin to be a viable treatment modality for one who has tuberous sclerosis complex just like EI. It was the scientific discoveries made during this time period immediately after 1986 and linked together to the idea of a genetic disease that fundamentally changed the lives of TSC patients. In the hospital, doctors had one more problem to look into. New masses had been found in EI's brain. The medical team had performed a study to look at the blood vessels in his brain. It showed that there was some swelling and fluid, but the masses growing weren't tumors. Shortly after the operation, EI complained of a massive headache, and pain medicines didn't work. He was given steroids to try to help limit some of the inflammation and swelling that could happen. There isn't a parallel timeline where EI would have magically gotten the treatment that he needed if they all ended in 1986. If he had been born 25 years later, it may not have turned out like this. Do you remember the seizures that he had in the first 2 years of his life? Well, those are called infantile spasms, and for each one that happens, it becomes less likely that the person will develop normally. But we have medicines for that now. Childhood seizures in tuberous sclerosis complex are also linked to developmental delay. Anti-seizure medicines are still given, but sometimes the patient won't respond to one, and a second one is added on. And if that doesn't work, a third, and then a fourth. And then it becomes less likely that the seizures can be treated with medicines the more medicines that are added. But we have multiple treatment modalities available now. mTOR inhibitor medicines based on rapamycin can shrink tumors that could be growing in the brain. Another medicine, not strictly for seizures alone, can be added on and has been shown to be effective and has been studied and approved for use. And because mTOR pathway is linked to insulin, a ketogenic diet aimed at limiting insulin level peaks in blood has also been shown to be helpful in reducing seizure frequency in some TSC patients. It's hard to imagine that knowing where ABO blood typing is in the genome allowed us to find a gene that makes a protein that checks a mechanism that controls cell size based on a signal sent by insulin, and that soil from an island west of South America would contain a bacteria that produces a chemical that stops that cell size mechanism that in humans would limit tumor growth and be able to treat some of the underlying problems of someone who has the genetic mutations of TSC1 and or TSC2. Understanding mTOR has also enabled understanding many other diseases. For example, diabetes is linked right to insulin and glucose, and one of the most common medicines for it, metformin, is upstream of the mTOR pathway. The heart can sometimes hypertrophy, that is, grow inappropriately in size, which would prevent it from properly ejecting adequate blood for each pump. And because we're talking about cell size as one aspect of it here, it has a link to mTOR. Because rapamycin was found to suppress the immune system, it was studied in autoimmune diseases, and derivatives of it were made for organ transplant, because the immune system will recognize a new organ as a foreign entity and then attack it, and the overwhelming response can destroy one's body. So, medicines to limit the immune system would prevent that damage from happening. Multiple pathways converge onto mTOR that all start from different signals, all of which have been and are still currently being studied. One final question that can be answered. Why did EI take the whole bottles of seizure medicine and vitamin D? It's hard to know the exact motivation, but it highlights that despite scientific advancements, care of patients on a personal level is paramount. 90% of TSC patients will be impacted by neuropsychiatric disorders, two of which can be impulsive behavior and forgetfulness, the latter possibly being associated with some level of intellectual disability that was associated with his somewhat untreated childhood seizures due to TSC. It deteriorated his mental health, and it brought him to the emergency room for the last time. 15 hours after his brain blood vessel study, EI started having a seizure. No one in the hospital was near him when it happened, and when the nurse went in to check on him, no vital signs were found. At autopsy, they found his brain had swelled so much that it folded over itself in his skull, along with the masses that come without the access to the right medicines for this genetic disorder. This video is based on two cases combined together, done this way to teach about tuberous sclerosis complex and all the discoveries and developments that led to our better understanding of it. The renal angiomyolipomas can result in fatal hemorrhage, but the presentation of it with polycystic kidney disease and renal cell carcinoma really highlight the genetic basis of this disease, and the resulting brain masses can impact a patient's cognitive development. EI is based on a real TSC patient from 1986 with this same outcome. But all of the discoveries and connection of ideas since then that are still happening today have helped positively impact patients with tuberous sclerosis complex. Thanks so much for watching. Take care of yourself and be well.